go ahead.
Yes. So when I was asked to speak, I really hadn't done a presentation in about 9 years. It was a bit difficult for me, but I think in the end I managed. I was asked to speak on a topic of my choice, and I chose endometriosis. I first initially wanted to cover the whole topic, but when I went and found information and read up on endometriosis and what's new and what's the latest, I found new ESHRE guidelines, European Society of Human Reproduction and Embryology guidelines, that were actually published this year. So the bulk of my talk is from that, and yeah, hope it meets the standard required. That is the entrance to where I go to work every day for the past 8 years. I work at Olivedale Hospital in Randburg, Joburg. I finished and specialized in 2013 in Joburg at Wits, and started here and full-time at Wits in 2014. So the outline of my talk is, there'll be an introduction. I'll go through the prevalence of endometriosis, touch a bit on the pathogenesis, look at the phenotypes that are there, and delve a lot into trying to diagnose this disease. I would show something on anatomy and staging of the disease, and talk a bit about its other clinical impacts. Unfortunately, like I said, it just became too big to try and talk of management. I am willing to do the management part of it at a later time. So what is endometriosis? Endometriosis is a benign inflammatory condition that you find in mostly in women through the reproductive years, but it has been said to be found in premenarcheal ladies or girls and in postmenopausal women. So what happens with endometriosis? There is ectopic endometrial tissue, which is basically your glands and your stroma, that is found outside the endometrium, and this is most commonly found in the pelvis, but can be found in other sites, and you name it, it has been found there. But what you'll find is the common other sites will be close, your organs close to your uterus and ovaries, which would be your bladder and your rectum and so on. So as an inflammatory condition, what does endometriosis do? So the most common things that affect us as gynecologists would be, it causes dysmenorrhea, it causes dyspareunia, deep dyspareunia at that. One of the things that the women will present with is chronic pelvic pain, and in a large set of our women, we will find that they present with infertility. Of interest is that symptoms may vary from minimal to severe debilitating pain. And interestingly is that the pain does not go with the stage. And so it doesn't mean that if a woman has stage 4 endometriosis, she will necessarily have pain that is a lot worse than a woman who has stage 1 endometriosis, for example. Endometriosis results in severe. Hello? Can you hear me? So endometriosis results in a lot of it has an adverse impact on a woman's quality of life, work, social, sex, education, and well-being. So it really affects women on many things in their lives. So when Zondervan study in 2018, what they were able to show is that the impact is actually comparable to your common diseases like diabetes, rheumatoid arthritis, and Crohn's disease. Part of what I that they published in the ESHRE guidelines is that there is a great unmet clinical need for improving many aspects of the diagnosis of the disease and the treatment of endometriosis associated symptoms. So they do acknowledge that a lot of research still has to be done to improve the diagnosis and treatment of endometriosis. Looking at the prevalence is said to be unknown, but it's thought to range between 2 and 10%. But what the research in fertile women found was that they found about 50% of these women to have endometriosis. Looking at those numbers, it is estimated that about 190 million women and adolescent girls worldwide are affected by this disease during the reproductive age, although it has been shown that women may suffer from endometriosis into their menopause. The pathogenesis is a bit difficult, and it's it appears to be multifactorial. There appears to be transportation of ectopic endometrial tissue from the uterus to the peritoneal cavity. There is some evidence to show that there is altered immunity as well, imbalance in cell proliferation and apoptosis, aberrant endocrine signaling, and they're said to be also genetic factors, because they have identified some genomic regions and abnormalities in cancer driver genes that are associated with endometriosis. The presence of these cancer driver mutations in non-malignant cells also may partly explain the aggressive nature of deep invasive lesions compared to your superficial peritoneal lesions. So the theory that there are many theories why endometriosis develops, but the main common theory is that of retrograde menstruation, where when a woman menstruates, there is flow of blood through the fallopian tubes into the pelvic cavity. Now, this has also been shown, in women who have retroverted uteruses, that happens. But of interest is that 90% of women have retrograde menstruation. In women, 90% of women who have retrograde menstruation, most of them did not develop endometriosis, which suggests that there are additional factors involved in this retrograde menstruation theory. The other alternative mechanisms that have been looked at is that there are, these ectopic endometrial cells may come from either the mesothelium, the stem cells, Mullerian rests, bone marrow stem cells, embryonic vestiges, lymphatic or vascular dissemination, or coelomic metaplasia. Now, there has been found that you can get endometriosis in premenarcheal girls. And this, the existence of Mullerian embryonic rests that are the result of neonatal uterine bleeding, including retrograde bleeding, have been thought to be caused by maternal estrogen exposure. The phenotypes, what you find I just thought I should put some pictures there and show some superficial endometriotic deposits. Now, in some patients, you find what would look like a typical lesions, and with different, what you see with a different color. So you can get sort of like red. I hope that picture is easily seen. You can get red deposits there, yellow, brown, endometriotic deposits, white deposits, and in some patients, what you find is that all you see in their pelvis is that they have peritoneal defects. These two pictures, the one on the left shows, this is in the pouch of Douglas. You can see towards the, towards the top left that there are some deposits there in the pouch, and that there are deposits on your uterosacral ligament on the right and just above it. The picture on the right is that of an endometrioma, or chocolate cyst as it's known. Now, this picture just shows your more advanced endometriosis, where you get obliteration of your pouch of Douglas. And I think what you can also see there is that there's an endometrioma and there's distortion of the left fallopian tube. Now, when it comes to diagnosis, the first thing that startled me is the first statement that's mentioned there, that the GDG, which is the guideline development group, said that laparoscopy is actually no longer the diagnostic gold standard and is now only recommended in patients with negative imaging results and or where empirical treatment was unsuccessful or inappropriate. We will delve into that a bit later. Now, the first recommendation is that the GDG recommends that clinicians should consider the diagnosis of endometriosis in individuals presenting with the following cyclical and non-cyclical signs and symptoms: dysmenorrhea, deep dyspareunia, dysuria, dyschezia, painful rectal bleeding or hematuria, shoulder tip pain, catamenial pneumothorax, cyclical cough, hemoptysis, and so on. Now, the study done by Byrne in 2018, this is where they managed to demonstrate that laparoscopy was associated with significant or potentially significant morbidity or even mortality, and as an invasive procedure, that's where they're coming up with the recommendation that it shouldn't be that gold standard to do laparoscopy for diagnosis. Now, what's mentioned is that a reliable and ideally inexpensive, non-invasive approach with high sensitivity and specificity would be the preferable approach. But because there isn't such a tool, the recommendation is that large-scale international multi-center studies are urgently needed, which will use novel technological platforms, meticulous standardized phenotyping, and have sufficient funding and an open mind for us to get to what we need, an approach we need in the diagnosis. So the second and third recommendation are such: they say clinical examination, including vaginal examination, where appropriate, should be considered to identify deep nodules or endometriomas in patients with suspected endometriosis, although they acknowledge that the diagnostic accuracy is low. And the third one is that in women with suspected endometriosis, further diagnostic steps, including imaging, should be considered even if the clinical exam is normal. So the difficulties is that in women with endometriosis, you can examine the patient and not find anything at all, but you've got a patient in front of you with all of these symptoms. Now, the other difficulty is that in the situations where a rectal and a PV exam are not really appropriate. For example, in your adolescence, religion, certain religions, and pain during the examination, or in patients who've had sexual abuse in the past, or who are Virgo intacta, which brings us to the other diagnostic modalities, which also have not been shown to be that effective. We'll look at a bit about imaging technologies. I'll mention one or two things about biomarkers and surgery and surgery in combination. Biological markers. There's been no biological marker that has been shown to be to reliably rule in or out of endometriosis. CA-125 has also not been shown to be useful. So there's no real biological marker that we can use to diagnose a patient with endometriosis. CA125, for example, is elevated in a lot of cases, including smoking and other things. Now, what they did was that they looked at some studies, and in the Cochrane review, they published a study in 2016 that looked at diagnostic modalities and what the outcomes were with those diagnostic modalities, and whether they could accurately predict if a woman had endometriosis or not. And they looked at your three phenotypes: your patients with superficial endometriosis, patients with ovarian endometriosis, and patients with deep endometriosis, and they compared with surgical diagnosis. What they found was that in patients who had pelvic endometriosis, none of the imaging modalities showed superior sensitivity and specificity to laparoscopy. Now, in patients with ovarian endometriomas, the studies that were assessing transvaginal ultrasound showed good mean specificity and sensitivity with reasonable confidence intervals and heterogeneity. A picture on the top right there is one of that shows a transvaginal ultrasound for a woman with an endometrioma, and typically that hypoechoic lesion that you see. Now, in women that had deep endometriosis, they found that for transvaginal ultrasound, the overall specificity and sensitivity estimates were reported to be around 94 and 97%, whereas the sensitivity may be slightly improved with 3D ultrasound. Of interest is that no data was made available on the minimum size of the lesion that was detected. What they found with your rectosigmoid endometriosis was quite interesting in that there was no significant difference between the methods used. So what you see there is that the sensitivity, the specificity and the sensitivity for MRI was similar to that of transvaginal ultrasound, which was 96 and 90%, respectively. So the recommendations 5 to 7 were that clinicians are recommended to use imaging, ultrasound or MRI in the diagnostic workup, for endometriosis, but they need to be aware that a negative finding does not exclude endometriosis, particularly those with superficial peritoneal disease. And then in patients with negative imaging results or where empirical treatment was unsuccessful or inappropriate, they recommended that clinicians should consider offering laparoscopy for the diagnosis and treatment of suspected endometriosis. The 7th recommendation was that laparoscopy identification of endometriotic lesions should be confirmed by histology, although a negative histology does not entirely rule out the disease. Now, this is a flow diagram. Unfortunately, I couldn't get the same flow diagram on one slide, but those are the common symptoms that the patients would present with. They also say that a symptom diary might be helpful for you when the patient comes in. Now, once the patient presents with all of those symptoms, it says that you should proceed to a clinical exam and then include your imaging. Once you've done that, you come up with a different differential diagnosis. If you think it's something else, you treat whatever it is. If there's signs of endometriosis, you can proceed to treatment, or go through further diagnostic steps. If you are convinced that it's also endometriosis, you can try empiric medical treatment for the patient. If you think the ovarian mass, of course, looks suspicious of something else, you should, proceed and investigate accordingly. When I was looking for, to just put up a slide on what a normal pelvis looked like, I came across this picture. Initially, I didn't even see that there's actually, they were doing a dye test, and after going through the slides a few times, I then realized that there's actually dye there in the pouch and in the right tube. But this is as clean as a pelvis can look. If you will look at some other types a bit later, but I know this slide it looks a bit small and all, but this slide is taken from the American Society for Reproductive Medicine. This is the revised classification of endometriosis. It is classified according to stage 1 to 4, where stage 1 and 2 are mild, stage 2, 3, and 4 are severe. And as you can see on the top left, you get scores. It's a scoring system, and these scores are either obtained at laparoscopy, laparotomy, or through images that are taken probably at laparoscopy. The main things to look for in this table is there's 3 things that they look at. They look at the presence of endometrial deposits, whether or not the partial or complete obliteration of the pouch, and the presence of adhesions. Going back to the endometriotic deposits, they're further subdivided into, are they peritoneal deposits, are they ovarian deposits, and whether those are superficial or deep, and a certain score is assigned to what you see there. With the adhesions, same thing. They look at are the adhesions affecting the ovary, or are the adhesions affecting the tube, and are those adhesions either filmy or are they dense adhesions? And you get a score. And as you can see, if your score is above 14 above, you get your endometriosis is classified as stage 4. And if you look where there's complete obliteration, by complete obliteration of the pouch, your stage is already 4. But yeah, that is the American Society for Reproductive Medicine revised classification of endometriosis. Now, the classification has one strength. It helps doctors classify patients and consult studies for best treatment. Usually, it's women who are stage 3 and stage 4 endometriosis that will most likely require surgery. But the weaknesses of the staging is that what they found is that doctors looking at the same patient disagree on the stage 50% of the time, and there was no correlation to likelihood to conceive. What clinical impact does endometriosis have? As we said, 50% of the women with infertility would have endometriosis. Women in pregnancy, it has been shown that there can be regression of the endometriosis, but there have been complications associated with endometriosis in pregnant women, like intestinal perforation, hemoperitoneum, uroperitoneum, acute appendicitis, ruptured or infected ovarian endometriomas. In our obstetric patients, has also been it's also been shown that there is an increased risk of preterm labor, increased risk of preeclampsia, and an increased risk of cesarean section rates. When it comes to women with, when it comes to ovarian cancer, there appears to be an increased risk in epithelial ovarian cancers, and specifically of the endometrial type and clear cell. There is also an association with atherosclerosis in your endometriotic patients. So in summary, endometriosis is a benign inflammatory condition that affects premenopausal, reproductive, and postmenopausal women. It is associated with, a greatly affected quality of life. Diagnosis is not always clear-cut. And most importantly, the diagnostic life scope is no longer the gold standard. Management is also complex, as I will probably present again in the next week or two. Thank you.
Thank you, Lesego, for that interesting presentation. Does anyone have any question or comments? Please just go ahead and unmute. Taku, please go ahead.
Thank you, Lesego, for that presentation. What I wanted to ask was, there was something about pneumoperitoneum there, and I didn't understand what that is. The word that came ahead of the pneumoperitoneum is new to me. Can you explain to us what that symptom or sign is?
I'm not too sure myself. If I may go back, let me just go back to my slide. I think I meant to mention hemoperitoneum. I must say that the couple of things that they mentioned there, I had also was not too familiar with. Just want to go back to what they were saying there, or what I put there. Yeah, that's I must be honest. When I saw that, I also didn't know what they meant with that uroperitoneum. But hemo is probably it's blood in the pelvis. But yeah, uro, I just didn't know what they said, and I had meant to go back and check what they meant by uroperitoneum, but I didn't have time. Hello?
Yes, thank you for the response. I
Yeah.
think we can all, if we can find what the term was, perhaps it will
Yeah.
allow us to follow it up, or we can put it on the group later.
Yeah, it
was a pneumothorax, wasn't it? It was something pneumothorax. That was the term.
No. The only term, I'm actually on the slide. I don't know if you can see, or if I'm sharing it.
We can't see the slides.
Is it?
Maybe,
sorry. Okay, it's fine.
May you please
we'll
share them again?
We'll discuss it later then. I'm struggling to.
Just try sharing your slides again. We still have time.
Okay. Okay. All right. Okay, I think sorry, I was presenting from my laptop, and because I had a problem with the audio, I think I came out of the meeting on the laptop, unfortunately. But yeah, we can discuss it on the group later on or tomorrow.
Sure. Stanley, please go ahead.
Thank you, Lesego, for your presentation. And if you want, actually, I think it's too standard, so don't worry about that. I think it's actually good. So I wanted to find out what you meant by that diagnosis. You no longer are required to have laparoscopy. Is it that you no longer require histology, or you actually don't need to do the laparoscopy? And then if we don't require histology, what symptoms can we use to diagnose endometriosis with some degree of certainty?
Yeah, thanks, Dan. So this past weekend, I was at a reproductive medicine conference in Pretoria, and the message came through there as well that instead of a woman undergoing recurrent multiple laparoscopies, what they suggest now is that in women that you suspect have endometriosis, you can treat them empirically with medical treatment, your Visens, your combined oral contraceptives, etc. And if they improve on treatment, then they say you can actually have a assumptive diagnosis of endometriosis, because what they're saying is that you don't want a situation where a woman comes in with 4, 5, 6 laparoscopies, purely because a lot of these women have recurrence, and yeah, so they're saying that you can, if a woman improves on your progestogens and other medical treatment, you can have an assumptive diagnosis of endometriosis, and if part of what the message that I got was that you must counsel your patients thoroughly. You must not, in this day and age, say to a patient, if we don't do laparoscopy from you, we don't know. We're not going to do anything. You must, if you've counseled the patient and the patient agrees to medical treatment, you can put the patient on medical treatment, and then if the patient improves, then you can assume that the patient has endometriosis and leave out laparoscopy. The ideal thing that's mentioned is that if you do laparoscopy, ideally you should take a sample for histology and confirm on histology. But what came through is that a negative histology does not necessarily mean the patient does not have endometriosis in some cases.
Okay, thank you. So in other words, you're saying that there's no role for, maybe I didn't get you well. Is there a role of diagnostic laparoscopy? Or because I read somewhere, they say if you are to do surgery, you should do it, which is therapeutic, and it's better for women to have one surgery for endometriosis in their life because these things recur. So in other words, if you can't really deal with endometric tissue, I think, and you suspect that there's endometriosis, there are other imaging modalities that you can use to look for this endometric tissue. And if you can't deal with them, I think it's better to pay to those who are able to do it, and they have one surgery, not multiple surgeries, because that also sensitizes their central perception of pain, because they're already in pain, and then they become stressed because you're not finding a diagnosis, and then their threshold of pain centrally is also lowered, and then they have more pain, and then they have a cycle of pain and pain and pain. I think that's what I got from another presentation that I attended on endometriosis.
Yeah. So, can you hear me? So, Stan, so I think we're saying the same thing but differently. What I'm saying is that the recommendation is that a diagnostic lab scope is not a gold standard. You don't have to do it. You can start the patient empirically on treatment. If the patient responds, you can then make an assumptive diagnosis of endometriosis and not proceed to surgery. And this, like you say, will then buy you time in terms of delaying your surgery. Because if you, for example, have a 23-year-old having her first surgery from endometriosis, you're most likely going to have that very same patient have fourth or fifth surgery for endometriosis by the age of 40. So the recommendation is that if you can wait it out. But if the patient after thorough counseling says that I want to be operated or I'd prefer to be operated, then you go ahead and operate. And yes, you're right. If in situations where you suspect that you're dealing with stage 3 or stage 4 endometriosis, it is ideal that you consult your an experienced laparoscopic a surgeon like Dr. Shaba and Dr. Vuma to do the surgery, because you would want the surgery to be done once. Because the biggest problem that I've seen is that you got a lot of situations where suboptimal surgeries are done, and then the patients have to go for repeated surgeries because of that. But I agree with you. In one of the presentations, when they talked about pain in endometriosis, they said that in about 50% of the patients with advanced endometriosis, there's about 33 to 50% of patients in the literature that report that the pain did not improve after surgery. So it's yeah. I will delve a bit into the management and show what the ESHRE guideline group came up with in my next presentation.
Does anyone else have a comment or question for Lesego?
So I think I would really like to finish this off with the management part of endometriosis, and we can have this discussion again, Stan, on what to do, what the recommendations are, because I think the ESHRE guidelines are universally accepted guidelines, and we'll see what the recommendation is on surgery and other treatment modalities.
I would also want to maybe pose the question in terms of the patho, if there's any inroads in terms of trying to find out what really happens at a cellular level in terms of estrogen, progesterone, and inflammation in the pathophysiology there. Like you say that the main theory is retrograde menses, but we also see that it happens in most women, but some women then do not develop these. And I think if we can find the role of what happens with estrogen, progesterone, we can try then to find, to understand the management that is recommended in terms of the medical management.
Yeah, I will look a lot more into that, but what my understanding is that endometriosis is estrogen dependent, and therefore the estrogen results in proliferation of these endometrial glands and stromal tissue when you've got an elevated amount of estrogen. But what happens exactly at what does the estrogen do? All I know is that it results in an inflammatory reaction process. But in terms of at at cellular level, what happens, I will, I can look that up and have a discussion when we present this again, or when we present the management, when I present the management.
Yes, sure. So yeah, I agree with you. There is actually an increase in estrogen. So estrogen will cause proliferation, and there's also progesterone resistance at that level. So then this will result in an inflammation that will then be recognized by the body as pain. So most women naturally have pain. They also have non-gynecological pains that they actually complain about, like migraine and so on. So they're actually generally in pain. So yeah.
Yeah, what I also is that they also talk about an upregulation in your sensory nerve fibers, which then leads to that sensation or perception of pain. But yeah, we'll delve a bit into that and maybe say a couple of things about it next time.
Thank you, Lesego, for the presentation. Thank you.
Pleasure.
Hi, Dr. Lesego.
Hi, how's it?
Good. Did you look at new evidence regarding microRNA in diagnosis?
No.
Of endometriosis?
No, I didn't come across that. Yeah, maybe you can enlighten us a bit. I didn't come across that in what I was looking at.
No. I think in terms of the new evidence regarding what we're talking about, presumptive diagnosis, there's also evidence coming up that you can use RNA, but I think it's still under investigation. So I thought maybe it was something that you looked at or something that was presented in the other fora that you're in. But if not, maybe you can look it up and maybe there may be something there. I don't know.
I'll definitely look it up and come back to the group about that. You said it's what you said it's mRNA.
It's about RNA testing, I think, in saliva.
Oh, okay. Yeah. No, that's fine. I'll check that.
Right, so Felix, just tell us what you know about that. Seems like you know something. You can just share with us, Felix.
No. I actually wanted to find out whether it's something that is being talked about in other fora, but then it's okay. It's just something that I came across.
So I will look at the pathophysiology of pain, and present a bit about that, because that was definitely presented this past weekend. I will then, before touching on the management, and I will look at that MR. You said MIN or MRIN, and present on that.
Thank you.
Thanks.
Do we have any comments from our mentors? Dr. Shara, I can see you managed to join, and Dr. Ndlovu.
Good evening. Sorry, I joined a bit late, and I hope you had conveyed my message that I was going to join late. But I think, Lesego, thank you very much for such a very enlightening presentation. And I think as long as we are able to get so many questions we need to actually come up with more questions than answers. Like this story of the RNA story, I think that is very important to go and look it up and see exactly what we can come up with. I don't know, Jackson, I think you joined much later. I don't know, do you have any comments?
Evening, colleagues. Thanks, Leslie, for a wonderful presentation, despite me joining very late. But I want to concur and agree with your statement to say, basically, there's no room anymore for diagnostic laparoscopy in patients where you suspect endometriosis based on symptoms. And the symptoms you are referring to those patients where you think they might be having minimal to mild endometriosis, where on scan you don't see any obvious endometriomas, and clinically you don't suspect a rectovaginal nodule, therefore you think it could be peritoneal endometriosis. The question is whether do you need to do a scope or not, and it has been shown by different authors, and the recommendations from the Endometriosis Society was that you need to treat prior to surgery. And if those patients improve, you need to give them a time frame, a minimum of 3 months on Visan. And if they do improve on medication, therefore, you can make a presumptive diagnosis of endometriosis and tell those patients that they need to continue the treatment, and endometriosis is a chronic disease. Therefore, if they stop medication, the chance that they will have recurrence of symptoms. Therefore, it is suggested that all patients where you suspect endometriosis and you think there's no indication for surgery, you should give them medical treatment and advice for minimal time period of 3 months. So there's no room for surgery. The only time where one needs to consider surgery is when the patient presents with infertility and pain, and you suspect that they cannot afford IVF for whatever reason. Therefore, whatever form of surgery that you offer those patients, it needs to be the first and the last surgery, preferably, because it must be done by someone with high volume surgery when it comes to endometriosis, so as to increase the chances of their fertility. Then we use the so-called endometriosis fertility index score, because we know that we've got different endometriosis classifications, from your ASRM to NZN score, and endometriosis fertility index basically will give you the prognosis of fertility post-surgery based on the tubal function, ovarian status, and pelvic findings. So I think, colleagues, the presentation, as I said, I joined late, but the few comments and suggestions that I had from the CEO, I think I agree with him that we need to try and treat prior to surgery. And the issue about mRNA, unfortunately, I've not seen or heard much about it. And I think it's something that we need to go and look at our literature. Maybe someone can comment better. That will be my contribution towards the topic. Thank you.
Thank you very much, Dr. Jackson and Dr. Shawa. Does anyone else have any further comments? Okay, it's 7:01. Thank you very much, Lesego. It was a really enlightening presentation on endometriosis, and we look forward to the second part of your presentation. Have a good evening, everyone. We've come to the end of our meeting.
Thank
you so much.
Thank you.
Thank you, Shippo. Thank you. Good night, guys.
Thank you. Thank you so much.
Good
Thank you.